We are live. Okay. We need to get moving. Today, this is Senate Finance. This is April 8th. And we are going back to take testimony. We did the walkthrough of H 585, which is the somewhat comprehensive insurance reform bill. So, which is, I think, really like 3 bills, or at least 3 bills put together. So we're going to start, and we have Emma Parody on up. Yeah, we just tell us your name, who you represent, and then the floor is yours.
Well, thank you. Good afternoon, committee. My name's Emma Paradise, and I'm the co-director of Common Good Vermont. And I think it's my first time in this committee, so thanks for having me in. Really appreciate the opportunity to testify in H585. Specifically, I'll be speaking to the health insurance governance provisions and the expanding access to association health plans pieces. And just since this is my first time in the committee, Common Good Vermont is a statewide program of United Way of Northwest Vermont, and we're dedicated to uniting, strengthening, and advocating for Vermont's nonprofit sector. And also, as of January 1st, 2025, we also became a member association representing over 200 nonprofits across the state. So just to start, I'd like to speak to the health insurance governance provision that would require representatives of the public, which would be individuals appointed by partisan elected officials to serve on certain nonprofit boards. And I did send a letter to the committee that I shared with the House Health Care Committee with more thoughts on this. But overall, we're just concerned that opening up the door to government intervention into the governance of independent nonprofits could really have serious implications for the sector at large. And this could include housing and human service organizations, those who are delivering other programs through state-funded programs. And we are just really encouraged exploring other options that achieve the same goals around transparency and accountability that are not at odds with core governance structures of nonprofits. But moving on, I really want to focus my time on association health plans. Common Good is deeply invested in ensuring that health insurance markets are accessible, affordable, and equitable for nonprofits that rely on stable benefits to recruit and retain staff. And in the face of rapidly rising healthcare prices, AHPs could really provide much needed relief to nonprofit employers and expand benefits to employees. We do approach this with caution, though. We definitely support the expansion, but we do feel it's important that there are appropriate guardrails in place. For context, as I said, we're a member association. Most of our members are small organizations. 55% have really small budgets under 500,000. Maybe small teams, 4 to 5 staff. Probably not the primary demographic for an association plan. But as most don't currently offer a health insurance benefit, but this could be a way to get those smaller organizations to provide health insurance benefits. About 37% of our members are mid-sized, 500,000 to about 5 million in revenue annually. And these organizations have more employees and probably are more likely to offer health insurance already, but they could find real significant cost savings potentially through AHPs. And then a small portion of our members are over 5 million, and many of these already offer pretty robust benefits, but could also see savings through this program. But regardless of size, managing health insurance costs is really a top priority for Vermont nonprofits. For those who do provide insurance, it is a driving cost. We do a biannual wages and benefits survey for nonprofits in Vermont, as well as the partners in New Hampshire and Maine. And in Vermont, in 2024, 94% reported premium increases, and that's compared to 52% in 2022. So really dramatic. And these increases were absorbed by employers and employees alike, Sometimes it was a higher deductible, or sometimes it was decreased coverage, but they really did have to make changes to benefits in order to keep offering coverage at all. And so we're really concerned that after seeing years of growth in the number of organizations offering benefits, in 2024, we actually saw a 2% decrease from 2022. So concerned that this is a trend that fewer nonprofit employers will be offering benefits. And for those who don't offer health insurance due to the cost being a barrier, this can make recruitment and retention really challenging. We're seeing more organizations look for alternative arrangements like ICHRAs, but also expiration of ACA subsidy. ICHRAs. Okay.
Word for me.
Yes. Sure. Courtney, can you? Oh my gosh.
I'll get
I got it.
Yeah, what did they do?
It's an alternative to, oh my gosh.
Is it
ICHRA, a health insurance management. Oh my gosh, I'm so sorry.
I can look that up.
ICHRA, and
It's an individual coverage health reimbursement arrangement.
thank you. I'm sorry. I should have
Okay,
had it.
we'll get a briefing on what those take money. We found somebody. Okay, keep going.
Apologies. In both cases, though, the expiration of the Affordable Care Act subsidies are also going to have an impact both on employers who may see more employees taking advantage of plans, or employees who rely on those plans but no longer be taking advantage of them. And so no matter where you stand, health insurance costs are really hurting our workforce, forcing skilled, mission-driven workers to choose between a career supporting healthy communities and their family's health. So Common Good sees expanding access to association plans as a real opportunity with the potential to provide affordable benefits and predictability to nonprofits and their employees in the face of a broken system. There's also the potential to reduce administrative burdens for small organizations through a shared system. And we have seen other state associations. We're part of the National Council of Nonprofit Networks. There's associations like us in other states, and they have seen real cost savings. Together, South Carolina is our South Carolina counterpart, and one of their members shares that in 2022, we joined the South Carolina's Association Health Plan, saving $50,000 annually while gaining access to high quality benefits alongside nonprofits across South Carolina. This collaboration has strengthened our ability to support our team while keeping costs manageable. As early adopters of Together South Carolina AHP, we're proud to show how nonprofits can leverage collective strength to create lasting impact for our teams and our communities. So that's one example, obviously a different situation in Vermont. But we also just want to urge a little bit of caution that we do want to make sure that we are protecting against adverse selection, ensuring that fair market competition is still in place, avoid situations where Vermonters are segmented and maybe uneven risk pools that may cause unwanted consequences for some and benefits for others. And so we just have to consider how association plans will impact the quality of benefits organizations and nonprofit employers receive, and also how those not covered through an association health plan would still be impacted, as well as Vermonters at large. There are also questions about what cost savings will be achievable. To be frank, Vermont has a small size and different demographics than other states. But I think, well, by no means a silver bullet, AHPs are the best chance we have at bringing down healthcare costs in the short term for nonprofit employers and employees. And I think we can mitigate and manage risks while still moving forward. So with these considerations in mind, Common Good would recommend clear guidance and disclosure requirements to ensure nonprofits understand the difference between different options available to them, require annual reporting on AHP enrollment, premiums, and benefit design, ensure parity in essential health benefits so that nonprofit workers are not offered standard coverage. And tonight, we would really encourage the committee to consider moving the effective date for AHPs to no later than January 1st, 2027 in House Healthcare. From the original bill, it was pushed back to 2028 with a report from DFR. And employers really need relief now. And while Common Good's ready to hit the ground running to stand up the program, we will need assurance that HPs will be allowed before investing the time and resources into development and implementation. And so we see these recommendations as key to creating conditions that support the successful and responsible expansion of HPs while mitigating unintended consequences. With proper guardrails in place, we're optimistic that the proposed expansion of HPs could provide much needed relief to Vermont's nonprofit workforce and would support the committee. We would support the committee moving forward this provision of the bill.
Okay, thank you.
Thank you.
Committee, any questions? Yeah,
we taken testimony on any of these at all?
that's what we're doing now.
Okay.
We did have an initial walkthrough of the bill.
Yeah.
Okay, just gathering information. Okay. I don't see the questions, so thank you.
Thank you.
Okay, Jessica Bartos.
Good afternoon, Hey, everyone. I'm Jessica Barkas. I am the Vice President of Public Affairs for Planned Parenthood of Northern New England and the Planned Parenthood Vermont Action Fund. This is also my first time in this committee, this session, which is great. Glad to be here. Planned Parenthood of Northern New England, we serve over 14,000 Vermonters across our 6 health centers, as well as statewide through our telehealth program. And folks really turn to us for that compassionate, high quality, affordable reproductive and sexual health care, which includes wellness exams, birth control, STI testing, cancer screening. No one is turned away based on their ability to pay. About 56% of our patients have low income, and we provide about 1.24 million in free and discounted care annually in Vermont. The Planned Parenthood Vermont Action Fund is also the leading advocacy voice for that legally protected healthcare in our state. Vermont law has very strong protection, as you all know, related to our right for reproductive and sexual health care. However, rights do not guarantee our access to them. And many opponents of this critical health care have realized that legislative bans are deeply unpopular with the vast majority of Americans. And so they have instead started using other tactics to restrict services like abortion. One of the ways that our federal government is overreaching into states like Vermont is by restricting funding, which then in turn restricts access to care. And they're also using other administrative tactics to influence and restrict access by questioning insurance coverage or billing practices. So we're really here today to oppose Section 4513, which is that addition of gubernatorial appointees onto the Health Insurer Board of Directors. Here in Vermont, there are already multiple nonprofit bodies that are designated in statute that have gubernatorial appointees. Some of them are even in healthcare. But the key distinction between what Vermont has done in the past and this legislation is that the appointment power exists because the organization is created or governed by law. This power does not extend to all nonprofits. So there are certainly nonprofit councils, boards, or commissions that are created in statute and then assigned public duties. Vermont insurance companies are nonprofits, but they are not created in statute and they are not arms of the executive branch. And this is a really important distinction for patient care, medical judgment, and public trust, right? Health insurance boards, while they don't practice medicine, they ultimately determine what medicine is accessible, affordable, and timely. And in a reproductive health setting, our rights mean little if we cannot access or afford timely and effective healthcare. So extending gubernatorial appointment power to nonprofits outside of this current scope is really unprecedented and raises some significant concerns for us at Planned Parenthood of Northern New England. Others can speak more to the legal risks related to like nonprofit entities becoming state actors or the fiduciary duties conflicts that may arise as a result of this gubernatorial appointment. But I'm really going to focus in on this provision from a reproductive health perspective, where I think there are layered dangers that go even beyond that general nonprofit governance concern. So first and foremost, it politicizes our healthcare delivery. nonprofit insurers play a critical role in enforcing coverage protections, benefit design, utilization management, and network policies directly determine access to reproductive health care. And board governance can shape how aggressively an insurer complies with or constrains those protections. So extending gubernatorial appointment power into this space risks politicizing coverage decisions that are meant to be neutral, evidence-based, and actuarial. And these risks could be felt even sharper in Vermont, where, unlike in larger states, a very small number of corporations play an outsized role. So a decision made by this board could easily become market standard for the whole state. So if a governor can appoint board members, that power of those members can then be used to influence which services are offered or funded, or to pressure leadership to end advocacy or policies that may decrease access to legally protected healthcare services. Nonprofit boards determine an organization's priorities, hiring, resource allocation, and viewpoints or advocacy speech. And political appointees on any nonprofit healthcare board could have a chilling effect on that speech or advocacy. And I think this is an important point for you all as our legislative body, right? Is that a health insurance board can reshape reproductive healthcare access without removing a single benefit from statute, simply by changing how that coverage is administered. So examples of that could include a slower or a more discretionary appeal process, more aggressive pre-authorization needed for abortion or gender affirming care, or even narrowing the definitions of what's medically necessary. We firmly believe that healthcare decisions need to be made by patients and their medical providers, and not by politicians or political appointees. And having political appointees on any nonprofit healthcare board really opens up a pathway for those political influences to have an influence on medical judgment and practices. So this legislation would really create a new precedent for government oversight in an independent nonprofit healthcare entity. And if enacted, this framework could be used as a model by other states to further restrict access to reproductive and healthcare. So if other states were to choose to adapt this model and require political appointees on their state insurers or their hospital boards or their local Planned Parenthood or other health clinics, they could essentially ban abortion or other forms of care without legislative accountability. So they won't need their state legislature to pass an abortion ban if they can work from the inside of these institutions to defund, restrict, or delay access to care. So medical independence is really a safeguard for patient care throughout our entire system, from our health providers to our insurers. And once you politicize any part of that governance, you risk politicizing patient care. So thank you for your time.
Okay, thank you. Questions, committee? I think that was very clear.
How many members are on the board again?
It
It says it can be no less than 1/6.
9, am I right in that?
We have Courtney Harness, Blue Cross and Blue Shield of Vermont. We have 12 members of our board. So this would replace 2 of them.
And if then,
So not a majority of the board.
no, it would be a 6th, not less
Not
than a
less than-
6th, Bill said. So if they don't want to remove 2 people, they'd have to go up to 15 members on the board. Okay.
And I think even without a majority, it could have a chilling effect, right? If the board leadership is saying, what are those governor appointees going to think of this policy? I better like walk this back or self-censor this before it even gets to a board.
Okay. It is a precedent. Okay. Any other questions? Thank you. Okay, we're going on to Sharon Gutland. We have Sharon.
My colleague, Mike Landsberg, has a limited time. Could
Okay.
he go ahead of me and then I will
Okay,
follow?
you.
He
have
is,
the next 2 slots,
He's
so
on
Zoom.
Zoom.
Okay, and we've got him, we will put him up. You can have the comfortable chair. You can see him without doing in your neck and eating
It's
physical
all,
therapy.
it's all good. I have two new knees and this is a good way to practice some functional exercise. Nothing off the floor.
Mr. Lansford, welcome to Senate Finance, and we just asked that you introduce yourself. Tell us who you're representing, and the floor is yours.
Sure. Thank you very much for the time, Madam Chair and committee members. My name is Michael Landsberg. I'm an athletic trainer. I've been practicing athletic training in Vermont for 33 years. And I work at the rehab gym along with Ms. Gutwin. My biggest reason for being here today is I guess twofold. First and foremost, there's a misunderstanding, I think, in the public of who athletic trainers are. And I know that in the House, when this was testified on, I did not testify, but there was a question as to, okay, why are athletic trainers included in this language here alongside?
Question here, so.
Yeah.
Good
So
to have-
alongside physical therapists and occupational therapists, we have a bad name. I've been cursed with a bad professional name for the 33 years I've been an athletic trainer. Essentially, we're not personal trainers. We're not fitness trainers. Athletic trainers are allied healthcare professionals that are trained in treating musculoskeletal injuries, as well as things such as concussion in physically active individuals. So we're a key part of the healthcare profession and the healthcare continuum for the profession or the folks that have those types of injuries. I was actually privileged to spend a lot of time down at the State House working on the licensure law for athletic trainers, as well as a law that reimburses athletic trainers, which was the first of its kind in the country. Vermont actually kind of stands, I think, alone. I apologize for that phone ringing in the background. Vermont stands alone as one of the only states that has such legislation. And that legislation is essentially a kind of payment equity or a non-discriminatory law. The reason for the inclusion of athletic trainers here is in Vermont, we have a significant shortage of providers in the physical therapy profession as folks are aging out and we're seeming to get not the influx of professionals. And athletic trainers have been working in the clinical setting with physical therapists in concert and also receiving referrals from physical therapists, providing the same care. And in many cases, you know, we have the same outcomes, if not better outcomes, depending on the patient population. And so that's why we were looking to be included or have this language where we're included alongside these professions. And this reimbursement key piece of it, I know that all you're concerned about is about the finance piece. You know, what will this do in the big picture? Is it going to save money? And I know that testimony was taken in the House that spoke to the fact that yes, Blue Cross Blue Shield, I think, estimated somewhere between $2 and $6 million if we go to site neutral reimbursement. And so what I'm, you know, wanting to make sure of is one, that you have an understanding of who we are as professions. And secondly, with regards to the athletic training piece being a part of it, that with site neutral reimbursement, that we're included in that sense of getting that equal reimbursement to the other professions because of if we don't, I think you're going to see professions or not professions, but organizations like the rehab gym. And Sharon's my boss. She would probably tell you that we wouldn't hire athletic trainers if we can't get that same reimbursement. So you would actually decrease the access that the patients have to providers in an already decreasing landscape that we're in.
Okay, thank you. Any questions from the committee? Okay, thank you.
Thanks,
Taking
Mike.
time.
Thank you. And you're in really great hands with Sharon. She can speak, I think, you know, at great length to the benefits of all this.
Having been lobbied by the rehab gym, I can vouch for them. They are at least one of, I think you may have more than one, but one is definitely in the city of Barry.
Yes.
It's holding on. It's struggling, but I'm committed.
Okay,
Thanks, Mike.
thanks.
Thank you for your time.
I just want to add that Mike and I go back even before the rehab gym. I met Mike, and I also was introduced for the first time with the profession of athletic training in a practice that was established in part by orthopedic surgeons who now since are at Tilly Drive. So the prominent orthopedic surgeon group were unsatisfied with the traditional physical therapy. And so the athletic trainers in concert with physical therapists produced greater outcomes. Outcomes pretty much that I think also save money in the long run. What I learned from working with Mike is this approach that is more involved in getting a person back into what it was they were working on before. If it was a sport, they were in tune with that sport. And they not only had to get that patient well again, but strong again and as fast as can. While physical therapists don't have as much pressure, and we are more trained to get people up a curb and into a building safely. So the application of athletic training in concert with physical therapy, in my strong opinion, is the best way to handle physical rehabilitation. I have also worked with we have physical therapy, occupational therapy. So occupational therapists in the outpatient setting, we have a lot of them involved with pediatrics and in schools. There's a great majority of them there. They're less used in like a clinic like the rehab gym, even though we've hired that, but they work with hands. Pretty much occupational therapists are more with the upper extremity in outpatient rehab clinics. But they also work with that person, getting them back into life, say, and driving again or whatever their goals are in an occupation. An occupation doesn't need not necessarily a paid vacation. It's your occupation. Could be housework and gardening and such. So I will then say it is rare that I think the finance committee gets a testimony on something that is not asking for money from anyone, government or payers, and also patients in this case, the public. I am here with a passion for healthcare reform. I have from the get-go. I have since college days in the 70s. This is my opinion, is that we need to be progressing past an old model into the future. And the whole reason behind my starting the rehab gym was to push the boundaries. And we understand what's insurance reimbursable. We have guidelines we have to follow to get reimbursement. We have contracts. But there's so much more that a physical therapist can do. So when I launched the rehab gym, I offered much of that. I offered more than I can now because back then the profit margin afforded that. But one of the reasons why I'm here today and really pushing site neutral billing is it will allow me to get back into the role of being a disruptive innovator that is sorely needed. So that said, I speak about the whole of healthcare. Yes, I'm a physical therapist. Yes, I have a business that incorporates physical therapy as a major part of it. But this is so much broader than that. This is about basically allowing there to be the ability to rebalance what has become an unbalanced healthcare system. 2 decades ago, 80% of providers of all forms, not just doctors, PTs and so forth, but nurses, they were independent. And that has actually reversed. Now most are really associated with hospital. We call that more hospital-owned care. And in this migration from community-based care into hospital, and not just hospital, but hospital systems, we've actually evolved the hospital into creating a mega system far beyond critical care. And what we have seen from this is a marked increase in the cost of healthcare and decreased accessibility. Okay, so these are factors that spike my interest. I am a solution-oriented person. I love a challenge. I don't focus on symptoms. I think we all can see the symptoms of the crisis we're in. I'm not bringing that up. I want to talk about what I see as a real solution, and it's exciting. And I think it's also exciting that if this bill is passed, no, 585, and this is section 7 of that bill, this will be the first in the nation. And it's meant to be a stepping stone. It's meant to be a way for us to evaluate whether site neutral billing really actually produces the promises that it offers. I will not, I mean, I know that we have Blue Cross and Blue Shield in the room, and they can speak about the projected savings. I'm after the discussion that I can present is how that kind of happens, how this is a good solution. Right now, we do know independence, and again, I don't speak just for the professions of physical therapy, occupational therapy, and athletic training. We all know primary care and other independents are suffering right now, and they're going out of business. This is serious. We have businesses at risk. If we lose the independent market, we won't be able to shift. There won't be that ability for independents to absorb and take on what would be the migration. And the solution is also a way for us to sort of take less attention and finances towards the administration of what services do, but right into the services themselves. We all know small businesses, they can turn on a dime. They don't have the bureaucracy of large businesses. We don't have a lot of people running our business. The business is run by the providers. And there's also a direct connect between the highest, which is in my role, to the front lines. I'm at the front lines, and I really depend on the front lines to help me guide this business. I think that that's what makes independence strong. The facts are we can get patients in and out of their rehab even before the hospital can maybe have their first visit. So accessibility is already there. We do need more providers, though, to take on more of the load. So if we could have the financial stability that we once had, we could then attract people from other states and hopefully athletic trainers, because I think that ATs would love to jump into this profession, but right now they're more led into, the other ways that athletic trainers can express their profession. So, and then it will allow us, right now we're in damage control. We've got things that need repairs. We are losing providers to the hospital because they can pay more. We are losing people to getting out of PT completely. We call that moral injury, where they just don't get paid enough to cover the frustrations that are involved with dealing with a lot of payers, not all payers. But we have payers out there that would love to deny payment, especially after we've already delivered it. There's nothing better than getting free care. And so what I am proposing is more of a plan that isn't mine. It's been in the process for over a decade, and actually the federal government are the experts in site neutral analysis, site neutral billing analysis, projections. They've already successfully implemented site neutral with physical therapy. Now we do get paid the same as the hospital, and they're the experts. What I see is exciting. I do see that there is headwinds for hospitals. I don't deny that there is going to be resistance, but what I have heard is less about the healthcare system and more about me, whether it be the owners of those institutions or the people that work for them. They're afraid, what will this mean for them? But this is the feeling, is that we as independents are already there. We've already learned how to make adaptations, already learned how to become more efficient. There is no better incentive to become efficient than when you don't have the money. You find the way. So I think that that my testimony too, I didn't want to spend time talking about what I wrote. You can read it. But I feel that this is an opportunity. I think this is a safe opportunity because most PTs are in the community, and also we're spread out, not like a hospital where people have to travel far. And if anybody's had PT, you know that this requires multiple visits. So we live in a climate that makes travel challenging in the wintertime. So you really don't want to travel far to get your care. And to stay with the plan of care, you got to stay with your number of visits. It's just the way our profession works. So I wanted to actually take some time to go into also what will create, I feel, the success, which is, I'm also very honest. You know, I don't try to sugarcoat anything. And what I think is possible as far as what we need to give attention to in making this site neutral billing a success is we need to account for the practices that take out Medicare and Medicaid. Not all do, right? And all hospitals do. So in fairness to hospitals, to give them the feeling like we are not thinking just of ourselves, I don't believe success is in dollars in the bank of a business or a provider. But so possibly site neutral billing should come with a condition that you will be seeing Medicare and Medicaid. There are other ways you could do an add-on to those that do and still allow, you know, site neutral billing for all. And then the other condition is we do have differences in costs of facilities. We hear the hospital talk about facility costs. Well, in the physical therapy realm, there's nothing within the square footprint of a hospital and PT clinic and the rehab gym. Actually, we have greater square feet. It's the pools. I mean, these are 24/7, 365 expenses, but the value of aquatic therapy cannot be replaced by other forms. And sometimes it's the only form of rehabilitation in a patient's need for rehabilitation to begin with. So I would say that's just the only thing that I could see that we need to give a little extra attention to. Now, I don't think we need to solve that now. I'm just saying possibly we will look at a bump up for those facilities. Now, the last thing I wanted to mention is I do believe in reference-based pricing, and you'll hear a lot of that. I also wanted to make note that the other initiatives that have been applied in the past to help independents and what's in the legislature outside of site neutral billing does not affect independents. So, and we thought there would be a trickle down, but that has not happened. Site neutral billing could do what none of the other initiatives can do, and it would be done organically. The legislature, the Green Mountain Care Board don't need to get involved. After it's set, then it'll be flushed out within the professional environment. So reference-based, meaning the reference is Medicare, CMS. Right now, CMS doesn't pay the fee schedule straightforwardly. In physical therapy, there's always multiple CPT codes, which are measured in like 15-minute increments. And in Vermont, most rehab is over an hour. What CMS has done is taken the first CPT code or the highest and given us 100% of that. But then it has been reduced for all CPT codes after that to basically take what would be otherwise, say, $120 a visit and has reduced it to 100. And so we have to be careful when we are designing the site neutral billing to make sure that the fee schedule of CMS is translated as is. And I don't think I can't think of another biller. There might be one that also does this multiple reductions. I don't want them to hear that happens. It's frustrating. Not even my biller can understand the bills when they finally get paid. But we basically get around $100. So that's not enough to pay the bills. When my cost of care is about 138 an hour. And so Medicaid is even below that. We got a reduction when the primary care went up 15%, we went down 15%. So it's between $80 and $100. We're talking about every visit the rehab gen will pay about $50 to treat a Medicaid patient. And this is why clinics have dropped them. That's a way to stay in business. And then the last thing is we might have a payer that takes advantage of this site neutral billing. I have no fear that Blue Cross and Blue Shield will handle this well in setting that rate. But I think it's important to have the Green Mountain Care Board just oversee it to make sure there's fairness amongst the commercial payers that are involved in this. They don't have to set the rate necessarily, but we need to just have some oversight. And I would think that, the providers and the insurers should provide that information to the Green Mountain Care Board of where the sweet spot is. We don't want to make it so that the hospitals suffer too much, but we don't want to also make the independents pay more than they need so that the benefit to the healthcare system is lacking.
We are behind schedule.
And then, well, that's it. So
Thank you. Thank you. I think this will be very helpful. Representative Black, I have one more.
Yeah, I'm super early. I just thought I would come down and watch y'all.
I think we may get to you a few minutes early because Representative North is not going to testify.
Okay.
So, I'm going to go on to Dr. Ritson. How much did I ask?
Brinson, but I am not a physician, although I appreciate the undeserved.
Come on up. I have MD.
Yeah.
We'll take that off. All right.
I'm also a first timer in this committee, so I
Well, welcome.
appreciate the opportunity to testify today. For the record, my name is Susan Ribson, not an MD. And I'm the executive director of Health First. We're an independent practice association, so we exist to promote and foster the success of independent practices. We represent roughly over 250 physicians and advanced practice professionals working in 66 primary care and specialty care clinician-owned practices across Vermont. In my testimony that I submitted, I did include some information about our network, just high level. I encourage you to look at that in your leisure. I also encourage you to consider me a resource if you have any questions about independent practice or our suggestions on this bill. I'm here in support of the House passed version of 585, particularly two sections. One, the expanded access to association health plans and the site neutral billing. The association health plans, I realign somewhat here with Ms. Paradis's stance on this. Our practices are small businesses, so they're buying health insurance for their employees. They're forced to do this on the exchange largely. The costs have gone up astronomically over the last several years. We need options. That is why we are in support of having the association health plan as an option. We do acknowledge that it's a potential threat to the exchange risk pool, shrinking that. However, the high cost of health insurance for our practice is an existential threat to some of them. So you may be losing them from the risk pool anyway if the rates keep going up. And on top of that, you'd be losing those options for care for Vermonters. So we would like to see those options out there. Then moving on to site neutral billing, we're in very strong support of this concept. Equal pay for equal work has been an issue that we've been we've repeatedly sought to remedy over the years. And Chair Cummings may recall some of those discussions that we had on this issue.
We have dealt with that in this committee before with an essentially different committee, but we did.
Yeah, so folks may not realize, but right now, a clinician could be paid 30 to 80% higher only for the sole reason that they are located in a hospital-owned environment. It could be the same level of training of the clinician, the same care, same equipment. The only difference is the location. And that is crazy. It's costing Vermonters more money because it affects their copay. It affects the employers, the insurers, the entire health system. It's crazy that it exists this way. It's illogical. And it's also quite unfair to those hardworking independent clinicians. And it results in even more struggle for these practices to compete with better resource entities. So site neutral billing, and as Ms. Gutland testified, this has been recommended at the federal level by a group called MedPAC, which is a nonpartisan legislative body that advises Medicare or CMS. They've done a lot of work around this, and it's a pretty clear money saver and common sense approach. It would correct this unfair and illogical reimbursement practice, it would lower the cost for all of us. And it done in a balanced way, meaning you're not just bringing the hospitals down to the independent level, but you're bringing the independence of some to help support them as we try to shift care out of the hospitals into the community. And just do it in a blended way. We can save money, not decimate the hospitals, but also support those community providers. Site neutral billing also discourages further healthcare consolidation, which has been associated with higher costs, which we are facing here in Vermont, obviously. And it better aligns payment with value and outcomes. So you're paying for that and not the location of where the service is provided when there's no clear reason or need for a difference. So H885, 585 as written, definitely is moving in the right direction and we support it. The push toward site neutral billing. We do think there's some opportunity. We do recognize the desire to keep the suite of codes focused at first. We do think though that, and we suggest that you consider strengthening the bill in two ways. One, adding language, and I did suggest language. I'm not an attorney, so legislative counsel could probably come up with better ways to say it, but the goal is to basically amend the bill so that that this site neutral work isn't kind of a one and done thing. That you're building in a ramp to evolve the policy over time. So you're not having to come back to the legislature to look at every service type to do it. You build it into the ability to expand over time. And then two, well, the physical therapy codes are a great place to start. We think that the benefit can be expanded if we also include a discrete set of, they're called E&M codes or evaluation and management codes. These are the codes when you go see your doctor. You have a new concern like a urinary tract infection. And I did include in the testimony I submitted some, and I can hand this out if this is helpful, but basically these are the codes that we're suggesting get added. There's no clear reason, there's no clinical justification for one clinician who works at a hospital or hospital-owned outpatient practice to get paid more than an independent clinician at an independent practice. So we think it makes complete sense to add these codes. The opportunity for savings is more. And it just makes sense to do so.
Okay,
So I appreciate the opportunity.
well, thank you. Committee, any questions?
Thank you, Madam Chair. Sorry, I missed the beginning of your testimony. I was in another committee, but I'm looking at your testimony in terms of the specific language that you're suggesting in section 7. Is it mostly just that you want the ability to, once these first categories are successful, then there's a way to move forward with other categories of billing without having to come back and change the law again?
Exactly.
Okay,
Keep the ball rolling.
so you're not tied to this language. That's just what you're trying to
Correct.
accomplish. Okay.
She said she's not asleep.
I think what you're gonna get from our hospital, it'd be the insurance companies and the cost and the impact on rates, because we're not, I don't think, suggesting lowering. We are working at lowering rates in another committee, hospital rates. But it'd be the impact on insurance premiums.
Yeah, but I think the point of this is that
Supposed to save money.
it's supposed to save money because there are some sites that are being billed higher than others for the same services. So it's not, the goal is not to bring everybody up to a higher
No,
rate.
it is to find
Or
the
or a
sweet spot, yeah, but as we know, most of our hospitals are in pinkish to reddish financial condition. And so how we transition, and we could find a transition, I suppose, hooked on the shade of pink at the hospital, where we could move to that, because we, in the past, have heard some really compelling stories from private practitioners. So,
Yeah, I mean, if you think about that, they're suffering too. They just go out of business.
Yeah.
Basically. And we have lost independent practices because they're not properly supported.
yeah,
So
okay,
I
thank you.
appreciate it. Thank you.
Okay, we're gonna get to Representative Black early. Representative Norton will not testify today. Okay, so welcome. We're getting late in this process, but walk us through your thought processes.
Well, for the record, Representative Alyssa Black, from Sierra House Healthcare. I want to make it clear that I am not the reporter of this bill.
Okay.
The reporter of this bill was Copper McFarland.
Oh,
And I'm pretty sure he resigned just so he would have to give me all the bills that are still him. So I'm gonna wing it for him. I did work, both Topper and I just call him Topper now instead of Representative McFarland. But
everyone else, yes.
Topper and I worked really collaboratively on this bill, particularly the Department of Financial Regulation. So I feel like I'm pretty well versed in it. I did even do a couple sections on the floor when we were reporting out the bill. I think you asked me in here to talk about, I believe, sections 1 and 2 regarding the governance
I
of
think
Blue
that
Cross.
probably.
But I'm more than happy to talk about the other sections.
Okay, that would be helpful, just
Yeah.
to know what and why, because there's several very distinct sections.
Yeah.
To this.
Is it the Susan's great testimony? I will just add the one thing that I have been around long enough, and I know that you have, and I know that this is something that has been discussed. It's not just that independent providers are going out of business, it's that they then are hired by the very same hospitals and the rates increase. I believe Chittenden County just lost its last independent oncologist last year. And that oncologist now works for UVM Medical Center.
And there are advantages, I believe, for malpractice insurance which
I,
is a big expense. Regular scheduling, no calls in the middle of the night.
I believe he made a very public case of the disparity between the payments that he was getting from insurers as opposed to hospital.
Yes.
So, questions 1 and 2. I know that, you know, as we were doing this bill, frankly, there wasn't actually a lot of controversy around these two sections until the very last day. I actually straw polled my committee on every single section in the bill to get, before we actually voted on the bill, to sort of get everybody's read on, you know, where they were falling. And I was surprised that I lost that straw poll in, on sections 1 and 2. Department of Financial Regulation came back in to retestify on it. I and the committee completely was swayed and was in support of including it after that testimony. I have heard this argument that somehow it's some kind of slippery slope for nonprofits. I will just say I've had to sit in many meetings, and I know, Madam Chair, you have been in some of those meetings with me. This is a insurance company that a year ago, we were seriously discussing insolvency and going into receivership. This is an insurance company that by most measures touches at least half of Vermonters. I'll bet if you went around and I asked you to pull out your insurance cards, half of you might have a Blue Cross Blue Shield of Vermont card. Insolvency would absolutely collapse our entire system of healthcare. This is not some folksy nonprofit. And, you know, understanding the financial situation that they were in, understanding their relationship with Blue Cross Blue Shield of Michigan. I mean, effectively, they are an affiliate of Blue Cross Blue Shield Michigan. And we think that there's 7 members of the board who are Vermonters, but there is veto power by the Blue Cross Blue Shield Michigan over who sits on that board. I just feel it's very imperative that with an organization and this bill, it is very specific. It will never affect some other nonprofit. It is written in the statute under nonprofit hospital service corporations, which we only have one in the entire state. I don't think anybody would think that we will ever have another one, particularly with the state of our
I think the
healthcare market.
concern we've heard. We may all love our present governor, but he won't be there forever. And we could get a governor that had very different political opinions around healthcare. And once we've set the precedent of having a governor court representatives on a private board, it's very, essential to the state of Vermont that precedent could be done to other boards, that other governors.
That would take
Like
legislative action.
It would take legislative action, and we may all love us too. But the agency out there knows that a third of us will probably not be here next year. That's our average turnover. And so that I think it's the setting of a precedent that's making people nervous.
I hear that. I'm not sure I agree.
Yeah.
It would, what it effectively would do is there would be at least two members on that board who are tasked with the Vermont healthcare system as a whole and Vermonters, rather than the aims and goals of Blue Cross Blue Shield of Michigan.
And maybe we should also talk about the Mountain Care Board and their role in this.
I will say,
Do we have a
Have-
problem with Michigan?
I don't know, but I would imagine that Blue Cross Blue Shield in Michigan's mission is not to the system of healthcare in the state of Vermont. I don't know what their mission statement is. I did want to say, to your point, and I'm looking over at DFR. I was a little concerned about having the governor appoint two. We went back and forth. I thought, well, maybe the legislature should have one appointment, maybe the pro tem and the speaker can appoint one member and the governor get another. And then it turned into, frankly, essentially a whole new Green Mountain Care Board nominating committee. And frankly, that exhausted me. So I'm like, fine, the governor can have two. So if you would like to change how these two people are picked, I'm totally in agreement. We really do feel like with an organization that's so imperative to the healthcare system in the state of Vermont, that perhaps there needs to be a couple members sitting on that board that are looking out for the welfare of all Vermonters, not just the financial bottom line of Blue Cross Blue Shield of Michigan or Vermont.
Thank you, Madam Chair. I'm just curious, and maybe this is more of a fair question for DFR than you. So if it is, please, I can ask them. They're all here. Which is Blue Cross Blue Shield got into a really bad situation, even though they were being regulated by DFR. So how did DFR not do their jobs well enough? And what makes us think that two members sitting on a board are going to have any more ability to prevent the financial collapse of the corporation than the regulator? I mean, DFR is the regulator, and maybe they didn't do a good enough job regulating.
I think that is a great question for DFR.
Okay.
I know that we did discuss that, but I will say that what happened with Blue Cross Blue Shield happened so quickly. It was a matter of a couple months of claims at the end, the last 2 or 3 months of 2023.
Yeah.
And I will say that they did prop themselves up by taking out $30 million loan from Blue Cross Blue Shield of Michigan at 8% interest.
Yeah.
That's Vermont ratepayers that were paying that interest.
No, I understand. I was involved. I was on healthcare, so I was following all this, and I remember how fast it happened. But I also sort of think it begs the question of what were our regulators doing? Why were they not watching the shop? And the governor appoints the commissioner of Department of Financial Regulation and all those people. How is this going to be any better than what our current system is? Our regulators, that's their job, and they didn't do it.
I will say, if I recall that time, it was the regulators that came to the legislature.
Right, but the Green Mountain, Blue Cross had been asking for rate increases for their reserves. We told Green Mountain Care Board, your job is to keep down the costs. And they regulated the rates
Green Mountain Care Board doesn't regulate the company, they
No,
just
it
regulate the
regulates the
insurance
rate.
rates. The DFR regulates the insurance companies.
And
So that's where I'm wondering what happened in that.
Yeah.
That, you know, and now we have DFR, the regulator, coming in and saying we want 2 members on this board. And I want to know why they didn't, why did they not know this was happening beforehand? And maybe we should be looking at better regulation of insurance companies, not putting members on private boards. Maybe this is part of it. I don't know. Maybe this is part of it, but I feel like that's the question that needs to be answered. They think the answer is to put members on a private board. And I want to know, maybe there's a better way to regulate insurance companies.
because this health insurance, DFR regulates other insurance companies, other kinds of insurance. They're the only ones.
Yep.
Health insurance gets split between the Green Mountain Care and DFR. And
But Green Mountain Care Board only regulates the rates.
but the rates
So
is the
their-
revenue.
Their ability, their reserves, their all of that stuff, which is
what goes.
is what DFR is looking at. And so maybe we need to tighten up what the regulatory body does.
We'll have you in.
I see you.
I'm going
I'll
to,
tell you if they make moves.
I'm gonna,
That's right.
you know, I'm gonna let DFR answer for
Yeah.
what they were
I
doing.
think that's a
I
question.
do wanna say just, and I can't, but I don't. Sorry, I'm apologizing for the board. I think the rate was actually actuarially accurate for what was thought of at the time that they would need for reserves. No one anticipated a massive claim surge. There was the last part of 2023 was unprecedented in hospital claims.
Okay.
But how would 2 members on this board make a difference? How would that have changed that? I feel like this maybe not be the solution to the problem we're trying to solve.
Yeah.
And so maybe we need better regulation. I just want to make sure that we're fitting the right solution to the problem.
I'm gonna let DFR make that case
Yeah,
for
All
you.
right.
We're gonna,
Yeah,
we are going to spend, I think, more time on this section
Yeah.
than any of the others.
I will say that there was an amendment on the floor to remove these first 2 sections. The member who did that ended up withdrawing their amendment. So, and then the bill passed. The committee did do a straw poll on that amendment, and the straw poll, I think, in our committee was 8-1. I think it was 8-1. We were doing a lot of straw polls that week.
So we will, definitely.
I know you asked me on sections 1 and 2. I just wanted to, first of all, the site neutral, I think Susan, did that.
Yeah.
I feel like we got the association health plan section to a really good place for a lot of compromise. And we're obviously all incredibly concerned about our QHP market and destabilizing it, but I really feel as though this sort of got to the right place. And I've been saying, I want the QHP market to be the place that we want to be. I don't want individual employers to have to become self-insured or like forming associations to try to lower their healthcare costs. I want to make the QHP market the lowest cost option. And we're working very hard on things. And I know you all are obviously on Senate Health and Welfare. I understand that. I want to make a plug for section 10. This is around healthcare sharing plans. There were 2 amendments to remove this. One was withdrawn and the other was voted down on the floor 103 to 26 to keep it in there. I have brought, and I'm gonna leave this with Chair if she would like this. This is just simply reporting. And frankly, I see it as a consumer protection. This is a viable option for many, many people who are struggling to afford, any sort of type of insurance. I want people to be confident that if they're planning on choosing a sharing plan, that they have all the information, that they understand that it's not insurance, that it's not regulated like insurance, and the legitimacy. I mean, anyone can form one of these things. Anyone. They're completely unregulated. We're not asking for them to be regulated. We just would like to know what sort of business they're doing in the state of Vermont. It is based word for word on legislation that came out of Colorado.
We were told that Colorado is in court.
I'm gonna let Jen Carby.
Yeah, I mean, we will look into that, but
Yeah.
that was the main concern, that until the court case is settled, we might not want to jump in feet
Yeah.
first.
And I believe we heard from the Office of the Attorney General, who had no concerns and was not worried. Okay, I just want to leave you, I have a copy of the report. I'm going to leave it with you in case for your own pleasure reading. And you can see just the kind of information that would be in Vermont's report. All right. Anything else on 585?
Any questions? Okay, committee, we're going to 10 minutes break. I don't